And I'm delighted now to introduce Anulika Ifesua, who is a health visitor. Hello, Anulika. And she is going to talk to us about how she's embraced and embedded the Brazelton approach into her work and her team's work in Manchester. So thank you, Anulika.
Susan, thank you everybody for attending this webinar today. I am going to zoom into Manchester to help us see what we've done and maybe begin to think about how you can now implement the Brazelton approach, how you will go about it, all the way to where we are at the moment. So I am going to look at every baby at the center of care, what a lot of organizations will describe as person-centered care, and how that applies to Manchester Health Visiting Service when we're thinking of individualized approach to all the babies, to all the children, and in effect, helping parents to find who their babies are and who their baby is to help them provide the best care for each child, not in comparison to any other child, but a child for the baby that they've got. So in general, in Manchester, newborn behavioral observation is a universal provision for all the families that access the health visiting service. And the health visiting service is a universal provision for every child from 28 weeks gestation in utero until the child is 5 years old. We are public health nurses. So all the health visitors are either midwives by background, or they are adult nurses or pediatric nurses by background. Then we have to go back to the university to study to become public health nurses or health visitors. So the way we have done it is to see newborn behavioral observation as part of the integral provision we give to families in Manchester. So I usually describe this journey using the tree. And often some people will say, oh, it's the embo tree. Yes, I think I'll call it the embo tree as I go through this explanation. So in Manchester, we have what we call the Healthy Child Program, which is what is available for every child in England. And the Healthy Child Program are those times in a child's life when they have to be visited, they have to be seen. There is opportunity for public health, interaction with the parents, opportunity to see where the child is at and give advice and look at what that family is needing. It's a whole system approach where we're looking at the babies and we're also looking at the family. And that Healthy Child Program, every child will be seen within the first 14 days post-delivery. We call it the new birth visit. And then they are seen again when that baby is 6 to 8 weeks old. And that's another Healthy Child Program visit. And what we did is to look at the newborn behavioral observation as a tree where we're going to hang in all the public health advice, all the things and the assessment that we're meant to be doing, considering that newborn behavioral observation is not an assessment, but from understanding the baby, the parents will be able to understand who their baby is, what the baby is asking for, what the needs might be, and then what the care provision for each child should be. So in effect, we have the newborn behavioral observation as a starting point. So instead of going into the house and beginning to ask questions and as if you're kind of interviewing parents and as if you're in a position of interviewing, we're actually doing things. And in the 6 to 8 weeks visit as well is when we do what we call the developmental review, the first developmental review of that child using the ages and stages questionnaire. So instead of going in and just doing the ages and stages questionnaire where you're going to be finding whether there's an anomaly, whether that child is meeting the milestone, we use the newborn behavioral observation. Yes, we might be able to see areas where that child might not be hitting the milestone, but then the parents will also be able to see a lot of strength and individuality of that child, with which they will now use to support that child in their growth and development. It's also a route for building relationship and alliance between us and parents and families. So they see us, when the parents see us, they see us as somebody who has come in to be part of their journey. It helps to build trust. There is less suspicion of who we are and what we do. And then within the newborn behavioral observation, we're now able to attach those public health messages, such as safe sleep, such as tummy time, feeding issues, and issues regarding sleep, issues regarding parent-infant relationship is built into that newborn behavioral observation. So in effect, it is not just doing the items, but it's an opportunity to just stay. And there is also opportunity to support parents about their parental mental health, and then to look for areas of sensitivity where the child might be communicating things regarding how sensitive they are, any evidence of fragility, and also to look at parental anxiety post-delivery and support them through that. So how did we do it? A general overview of what we did was, in the United Kingdom, there was a launch of the 1001 Critical Days manifesto, which is from conception to the first 2 years of life, being very critical for when the formation of that baby is taking place. And understanding that investment in the early years, in that very first few years of a child's life, is very important when we're thinking of the overall outcome for that baby. So when the 1001 Critical Days Manifesto was launched, we started thinking of what to do to build in infant mental health and parent-infant relationship into our practice. So in 2017, we managed to get the funding, and we started the rollout of the newborn behavioral observation for all the health visitors. And one of the key things about what we did in Manchester is to make sure that it's not a postcode lottery. Wherever you are in Manchester practicing as a health visitor, you should have the skills to be able to deliver the newborn behavioral observation within your practice. So we got the first funding, and the funding was to train everybody. By 2018, we have trained 149 health visitors. And the next thing we did was, while we're training, to have a support system in place for not just the training, but for supervision. And that included peer supervision, looking for champions, developing champions, and then supported the health visitors through the process of certification. Because it is not just the training, we have to look for the aspect of validity so that people are able to deliver the newborn behavioral observation effectively. Because often, as medical practitioners, we tend to fall back into assessment and trying to find problems, trying to find fixing problems. However, when they are supported to be competent, then they are now able to deliver the newborn behavioral observation as written and as expected. Then the next thing we did was to secure funding, because every year there will be new health visitors that will be trained in Manchester. There will be people that will be joining the workforce, and we want to make sure that when people are joining the workforce, we have the ability to train them. So we secured the annual training funding. The annual training funding is now in place because it is part of the integral provision for health visiting. When we're thinking about clinical competence and the competence of the practitioners, we have that embedded. So it is now fully embedded into Manchester. And then the next thing that happened in Manchester was a spread. Okay, all the services that work with families started thinking about doing newborn behavioral observation, what I describe as a piggyback, because already there is a structure in place. And that service included some of the early years service. The Thriving Babies project is a project in Manchester that works with families where there are a lot of additional need. For example, families that might have social services involvement might be at the age of social services involvement, and we train the first 15. And then they have their support system from the health visiting service to go through their certification. So thinking about how to go about it, I just thought I need to think of strategic thinking. The leadership structure of organizations that will look at perinatal and infant mental health as a way forward. So what we did is Manchester was the appointment of a specialist health visitor for perinatal and infant mental health. And of course, I was in that position and I'm still in that position, although I've taken additional role on top of it. And what I did was to make sure that is a system in place, the pathways, the policies, the standard operating procedure for what to do. And then we agreed the training pathway, we agreed the competency framework. So we looked at the infant mental health competency framework, and we looked at perinatal mental health competency framework and thought of how to bring it into what we are doing. We thought about record keeping, documentation, because the newborn behavioral observation needs to be documented in our already existing record. And it was a time when we're going into the electronic recording system. And we used the electronic recording system that didn't have the newborn behavioral observation or the newborn assessment scale built in the system. So I had to work with an IT, with the informatics to make sure that we built the template. So already there's a template in place by the time we started rolling out the training, so that practitioners have something in place for how they would document it. And then, of course, the system for supervision and the support, the ongoing learning was put in place, and then the strategic leadership for internal and external collaboration. So currently in Manchester, we have a GM approach. GM simply means Greater Manchester approach to the Brazelton approach. So what I do is every year, we have to do a newborn behavioral observation training, but I might not have the number in Manchester. I will reach out to the neighboring local authorities, the neighboring organizations, and ask them if they have staff that they want to train. So I need to get about 16 people to come together. So the recent one we did last year, we had about 4 different organizations come together to do the newborn behavioral observation. So I've talked about the process of funding for the training in 2017, the structure for the rollout of the training. The way I did it is to think about change management when we started rolling it out. It's important that the most enthusiastic of your staff are trained first, because when they are trained first, they're more likely to come along with it. So what I did was to advertise the first training, put it out. I didn't put out the whole training. I didn't say, send your staff to come to the training. I just said, I've got this training. And then the people that really wanted to do it came out. So I had the initial 40. By the time I trained that initial 40 and they was going through their certification, they were now in place. And I made sure that those 40 came from different teams. So for every team, there will be about 1 or 2 people that have been trained, that will be around to support the people that will come later on, the people that will need, the managers to say to them, you really have to do the training. So the support, that's why I described the enthusiastic first and the vision for MBAS practitioners in Manchester. We have MBAS practitioners working alongside, and the MBAS practitioners also sit within teams. But what they have is like, you have about 1 MBAS practitioner for about 2 teams. So they support the MBO, and they're also to pick up when there is an additional need where we need to go back and use the MBAS to work with the family. So I've talked about the electronic recording system that is now built in. I've talked about system building to include MBO and the MBAS template in our recording system. I've looked at the internal system for continuous support and certification, the system from the Brazelton Center. So we have good alliance with the Brazelton Center. I will only need to email or pick up my phone call and somebody will respond. And of course, because we have the support system through the trainers in the Brazelton Center, the staff in Manchester can join the webinars and they can be supported. And then of course, we have the support from our managers, and then we have the leadership support. it's really important that we have the managers and the leaders come on board. For a lot of the managers, they don't go out to work with families, but some of them decided to come and do the training. And what they did was they just wanted to have a feel. And some of them didn't do the training. They just said they're going to come and sit in for the first hour, or to sit in for the second hour, or to sit in for half a day or for a whole day, not the 2 days. Well, in effect, what we are trying to do is to, just to get a feel of what it is. So when the managers are enthusiastic and the leadership support is in place, we now have, again, the GM, the Greater Manchester system-wide MBAS and MBOS support. So where I need some support, I can always reach out to Tameside or to Bolton. I just need to send an email to the clinical leads for perinatal or for parent and mental health and say to them, I'm running an MBO training. Have you got staff? And then it's kind of a whole system approach to work it. So the benefit for parents and practitioners, what we have seen so far. For parents, I put out some of these quotes because these are some of the quotes that came out of the evaluation. This is the Brazelton evaluation form that we give out to parents. So one of the moms says, in her own writing, I just screenshotted and cut out a quote. Baby has been responding more when I try new things. I've been playing more with my baby and trying to respond. I can manage better now. I can let him be who he is without trying to change him, and let him guide me on what he wants to play. And that helps me to stop overstimulating. And then you see the other one that said, thank you. That visit was amazing. Thank you for insisting on it and making it happen so soon. She taught me things about him that I hadn't realized. I didn't know. Today is such a better day. He went to sleep at 11:50. Jason is a different name. I just used the synonym, a pseudonym there. Jason went to sleep at 11:50 at the end and is still asleep 2 hours later. Mom said, I can't believe I'm now having time to myself. I've eaten lunch and everything. She's happy that she now has strategies to use in caring for him. This is from the health visitor. And she copied some of the quotes from the mom, and then she added this quote and sent it to me. I'm just going to give us a quick story of a baby that I went out to see. The health visitor is going out to see this mom. Using the MBO, she's seen the mom and the baby, and she just said to me, Angolika, I think you need to go and see this parent. There's a lot of unrealistic expectation. There's a lot of anxiety, a lot of worry. And it was a baby that was born with craniosynostosis, a baby that was born with the brain sutures fused. And when I went in and I saw this parent, the mom was far away removed from the baby. The dad was coming a bit closer. And of course, what was sitting on that table that day was craniosynostosis, and they couldn't go beyond it. A mom said to me, I don't really want to invest into this, because she's gone into Google and she's seen a lot of things on Google that tells her that this child might likely have autism. And the more she looked at that baby, she wasn't ready to invest. She wasn't ready to commit. She said she didn't want to put in too much. Dad was trying a bit, but then of course there was that pull away from their baby. I said to them, let's have a look at your baby. Let's look at her together. First child, first baby. I said, let's look at your baby together and see what your baby is trying to tell us, because every baby speaks through their behavior, and every baby is an individual. And that will help us to understand where she is and where she's going and where we might be going with her. And then I started using the Newborn Behavioural Observation, which the health is to use. But on that day, I decided to move a little bit further into using the newborn assessment scale. Just a lot of the content of the Newborn Behavioural Observation, but just move a little bit and add a little bit more item. And it was a social interactive item. The more we went with this baby, because it wasn't me doing things, it was the baby doing things. And mom was moving. Initially, she started leaning forward, and she said, oh my goodness. When this baby was looking and following and interested, and then she spoke, and this baby turned to her. She just thought, oh, the baby was, they were preparing the baby for surgery, and she was worried about that surgery because the surgery is going to take place in the next 2 weeks. She was worried about the surgery. She was worried about everything. And suddenly, she leaned forward. She came forward. And she said to me, it's all right. Could she do that? So she could see the strength in her baby that she could hold on to take the next step. That did not remove the cranial synostosis. It didn't remove the fact that they were going to have the surgery, but she saw her baby. She met her baby for the first time. By the time I was leaving that house, I saw this mom holding her baby, looking at her. I think that might have been the very first time she looked at this child. So, to all the managers, what I would say to us is, it is cost effective. It doesn't add additional money, additional time, additional money. Instead, these parents are less likely to keep coming back with a lot of worry. It empowers practitioners, it is time saving, and it doesn't add more time to the practice. Thank you.
Thank you so much, Annalika, for such a riveting story. And I'm sure that many managers who are listening will be inspired. And thank you for such a detail of how to go about embedding the Brazelton approach in your service. So thank you so much.